Chers amis, bonjour à nouveau. Fin de la pause. Reprise du programme. Fin de la pause. Reprise du programme. Bonne session. It says, all you need is smash. Woo-hoo! All you need is smash. Everybody now. All you need is smash, smash, smash. All you need is me. Good morning again. Good morning for everybody. This funny song you've just heard, recorded at IHS Hamburg, is a nice introduction to welcome our German friends, Henning Niebuhr, Wolfgang Reinpold, Ferdinand Koeckerling, Ralph Laurenz, and Guido Bachebel. With Ralph and Wolfgang were my co-workers in the IHS board, and they regularly participated in the MESH Congress. And Ralph, after 3 presentations, was awarded to be an honorary member of the Hernia Club, which obviously it's a very high-level award. I'm very happy and proud to introduce the Professor Ferdinand Koeckerling from Berlin. Is not only one of the world's most outstanding hernia specialists, but also, according to Giampiero Campanelli lecture in Hamburg, he belongs to the Bishop Council of the Holy Hernia Chapel. 10 years ago, with some friends, he created HerniaMed, currently one of the most renowned hernia registry. 10 years after, today, hundreds of thousands of patients have been registered in this registry. This HerniaMed is a tool used as a medical device vigilance, is a source for an impressive list of scientific articles promoting the value of registries compared to RCTs. It's a tool for evaluating innovative techniques and procedures. It's also a tool to assess the quality improvement and a tool for certification of hernia centers. And last but not least, Ferdinand, with others, factually demonstrated the increased complexity of abdominal wall hernia surgery, and this way gained a formal integration of parietal surgery as a subspecialty in the UEMS. Today, HerniaMed is an auto-run engine. To be certified, you must register your patient in the HerniaMed registry. This is the German engineering, Dutch Qualität, sorry for the misspelling. So it's a real honor and real pleasure to have you, Ferdinand, in this MESH 2020. And the floor is yours, and we are eager to listen to your lecture.
So sorry. Thank you very much, Jean-François, again, for this really outstanding introduction. It's too much of honor for me. It's a teamwork. I would say what we have reached in the last years with our HerniaMed registry is a teamwork of many enthusiastic hernia surgeons in our country. It's the same as in your country with Club Hernie. From your registry Today there are also many nice papers coming out all the time. So that shows how important registries are. And what this also shows is that this type of surgery has become so complex that we need more specialists on that field. And you are, with your registry, also demonstrates that all the time. And I'm very happy about that. And hopefully we can in future join our registry data that we even more informations get out of these excellent tools for research on the field of hernia surgery. I have to thank you and your organization team for the honor that we got the possibility to organize a German session within your well-known yearly conference. Everyone knows how important your meeting is all the time, and it's a special honor for us that we are part of it, this, and that also shows our good relation, our cooperation over many years. And I hope for the next years, when this Corona catastrophe is over, that we return to face-to-face meetings and we can have a good glass of French red wine together and support further our good cooperation and friendship. So again, for the whole group, thank you very much for this really outstanding honor you gave to us all, and I hope we will have a very interesting session now. Yes, hello, good morning. I'd like to thank Jean-François for inviting me and the German group for his important event. It's a pleasure and honor for me to be co-president of this conference, and I hope we will have an interesting time together. What I want to present you today is some important findings on ventral incisional hernia repair from the HerniaMed registry. We start with the necessity of follow-up time in various hernia types. As you can see here, you see the recurrence curve of incisional hernias in comparison to inguinal hernias. And what you can nicely see here is we need a minimum of 10 years of follow-up before we can really find the recurrence rate after incisional hernia repair. After inguinal hernia repair, it's even longer, it's nearly 40 to 50 years. So what you can learn about that is we need long time to follow up our patients before we can be absolutely sure how the outcome of our patients is. Another important aspect is, and the same has been published by the French registry, that pooling of data of ventral and incisional hernia repair is critical. Why is it so? As you can see here, is operation procedures and outcome are highly significant different between ventral hernias and incisional hernias. So pooling of data from ventral and incisional hernia repair means to put apples and oranges in a box, mix it, and something comes out, but this is not the truth. So we should, in future, always separate these hernia entities when we try to analyze outcomes after that procedures. In the guidelines, it's recommended to use laparoscopic over open repair in incisional hernias with defects up to 10 centimeters. This is a recommendation in the guidelines. But on the other hand, there is always a strong discussion on meetings concerning the best placement of the mesh in the abdominal wall. And there is more and more coming out reports about serious complications after intra-abdominal mesh placement. And these discussions always lead to the demand to look for better procedures, minimally invasive procedures to place a mesh outside the abdominal cavity. Nevertheless, when we compare in our registries open sublay with laparoscopic IPOM, as we have done it here in this propensity score matching, comparing nearly 4,000 laparoscopic IPOMs with 4,000 open sublay procedures. And after propensity score matching, you see the patient population is really in every aspect comparable. There are no differences in all these various influencing factors. So these are very reliable data. And what you can see is, yes, there is a higher risk of intraoperative complications with laparoscopic IPOM. This is still the Achilles heel of laparoscopic IPOM incisional hernia repair, mainly bowel injury. But on the other hand, the postoperative complications are significantly better after laparoscopic IPOM compared with open sublay. So we have a lower, significantly lower postoperative complication rate. We have a significant lower complication-related reoperation rate. And also we have a significant lower general complication rate. So that means this outcome leads to the conclusion that in agreement with meta-analysis and guidelines, minimally invasive approach on the evidence-based situation, the gold standard in incisional hernia repair. These are the best data we have in the moment. This is, we have to say that right now it's still the gold standard. Although we are in a search for better minimally invasive procedures. I come to that back later. Beside these comparison of surgical techniques, we also have to look very carefully into technical details we use. And one important point is the type of mesh we used. And what was proven in our registry is that there is one mesh which has a significantly higher recurrence rate in the 1-year follow-up in comparison to all other meshes on the market, which can also be used in laparoscopic IPOM. And this is not only a finding of our registry, our Danish colleagues had the same finding a few years later with a longer follow-up. And you see again here, we have significant differences with the one mesh, which has meanwhile retrieved from the market in comparison to all other meshes used for laparoscopic IPOM. So we also have to look for details in the technique to better learn how the best way is to go to do our incisional hernia repair. I told you we are looking constantly for new minimally invasive approaches in incisional hernia repair. And one way which has been introduced by Wolfgang Reinbold, who is also with us today and will present his technique later to you. This is the new eMILOS or MILOS approach. What is a minimally invasive procedure, making the sublay retrorectus mesh placement via a relatively small incision. And we have performed a propensity score matching with his technique. All patients put in the HerniaMed database, and we have made a propensity score matching with laparoscopic IPOM and with the sublay procedure, which are the standards for comparison today. And what we found in this, and this is published in Annals of Surgery, that MILOS really has the lowest postoperative complication rate has the lowest complication-related reoperation rate, lowest general complication rate, and also the lowest recurrence rate. And the chronic pain rate is also less than after laparoscopic IPOM sublate. So the consequence is, this is a new minimally invasive approach which places a mesh not into the abdominal cavity, but in the sublate position. And with this technique, you can get better results as with laparoscopic IPOM and with standard open sublate procedure. There are other techniques developed in the last years, like ETAP and TAS and other procedures who do nearly the same. They all bring the mesh in the sublate position, but via a minimally invasive approach. In another analysis, we try to find out what are all the potential influencing factors on the outcome in incision hernia repair. And as you can see here, when you not only look for the statistical significance, but also to the odds ratios and consistent results in different testings, then you find out which are the most important influencing factors on the outcome. And as you can see here on the early outcome, so means outcome 30 days after the procedure, you see the width of the hernia defect is one of the most important influencing factors on the outcome, because a defect larger than 10 centimeters leads to more intraoperative complications, postoperative complications, complication-related reoperations, and general complication. This is the reason why large defects in widths more than 10 centimeters are today classified as complex incisional hernias. Another aspect is female gender. We didn't know that before, but you see here there's a very negative influence on the chronic pain rates after the operations in 1-year follow-up. You see that there is a highly negative influence of the gender to the disadvantage of the female gender on the chronic pain rates after incisional hernia repair. And another influencing factor is the preoperative pain. If a patient has preoperative pain from his incisional hernia, he has a higher risk of getting also a postoperative pain after incisional hernia repair. There are multiple others potential influencing factors, but these are the most important ones which we have to consider in all our decisions in incisional hernia repair. What is sometimes very interesting is also to see trends in the development of procedures and techniques. And we are now on the way since 10 years with our registry. And after the 10 years, we want to know what has changed over the time. You see here the numbers included in our registry over the last 10 years. You see in the beginning, the number was not very high. So we started to analyze in 2013 with quite a good number of yearly cases in our database, based on compared it with 2019, where we have more than 10,000 cases a year. This was the basis for our analysis. Totally, we saw open sublate repair in this whole series in 37%, laparoscopic IPOM in 27%, open IPOM in 12%. You see, still there is laparoscopic IPOM in 27% all over the 10 years. But in the further analysis, we looked more in details and compared the years with each other. And what is surprising on the first view is, you see here, the number of small defects increased from 34% to 39%. These are defects smaller than 4 centimeters. Why is it so? We have speculated this is probably due to the fact that we get more trocar hernias in our case series. You see here the number of patients with previous laparoscopic procedures like gallbladder removal, appendectomy, and inguinal hernia repair increased constantly to a higher percentage of all patients. And typically in all this procedure, the first trocar is placed around the umbilicus. And this leads to obviously more trocar hernias, and that is the reason for the increase of smaller hernias in the total population. And now this is an important slide here, which shows you very clearly that the surgeons more and more tend to go away from laparoscopic IPOM, because laparoscopic IPOM reduced from nearly 34% down to 21% over the last years, from 2013 to 2019. And what happens due to this? The number of open sublays increased, and we got more new procedures, which are summarized in our database as other procedures, going up to nearly 10%. In this group, you find ETAP, you find EMILOS, and other new minimally invasive approaches. That means the surgeons refused more and more doing laparoscopic IPOM and switched over to open sublay and the new procedures. But I have to say this switch to more open sublay is a little bit critical, because I have shown you that the postoperative complication rates of classic open sublay are significantly higher as after the minimal invasive approaches. So we should support surgeons to switch over more to minimally invasive alternative techniques, not laparoscopic IPOM, and not switch over to the sublay procedure. So some additional findings. Again, you see here that the open sublay has more complications and a higher reoperation rate. You see here 9% postoperative complication for sublay, 4.5% reoperation rate for complications, and here again 3% for laparoscopic IPOM and 1.3% for complication-related reoperation following laparoscopic IPOM. You see here the surgical site occurrences following primary elective incisional hernia repair. This went down a little bit, so that means this is the influence of the minimally invasive procedures. And here are the pain rates. They are still high, so we always look for recurrences after incisional hernia repair, but the rate of recurrence is also relatively high after the incisional hernia repair. You see here we have pain at rest and pain on exertion, chronic pain requiring treatment, 7.6%. This is pain on exertion and pain at rest. So these are relevant pain rates after incisional hernia repair. And this is the total recurrence rate in the 1 year follow-up, which tends to become a little bit lower than in 2013. So as I hopefully can show you that such analyses are also important to see some trends. Now I switch over to umbilical and epigastric hernias. We have got a few months ago the new and first guidelines on umbilical and epigastric hernia repair. And one of the important messages of the guidelines is the recommendation that we should choose a mesh in all defects larger as 1 centimeter, or starting with 1 centimeter defect. This is one of the major recommendations with the strength of strong that we should use this technique. We also made an analysis of all small umbilical hernias in our database. And as you can see here, we also found that that the suture repair, in comparison to open mesh repair, has a highly significant higher recurrence rate as the open mesh technique. So we support with our data the recommendation in the guidelines that the mesh use should be extended also to small hernia repairs. But how is the reality? We did the same analysis of our patient population over the years. And as you can see here, in Germany, Austria, Switzerland, which countries participated in our HerniaMed registry, the percentage of suture repair of small umbilical hernias, so that means less than 2 centimeters, is 75%. So that means the majority of small umbilical hernias is still treated by suture repair in our countries. And this is far away from which is recommended in the guidelines. And we will see over the next years if the guidelines have any influence on the choice of the procedure, and that the surgeons use in future more meshes as they do it now. And we also looked for influencing factors on the outcome in small umbilical hernia repairs in a large patient population. And what you can see here is laparoscopic IPOM versus suture, and laparoscopic IPOM versus open mesh has a very negative influence on the pain rate. So obviously, laparoscopic IPOM in small umbilical hernia repair leads to a very high pain rate after the procedure, and therefore it needs to be critically viewed when to indicate laparoscopic IPOM in small umbilical hernias. Again, female gender is a very negative influencing factor on the outcome. Again, female gender has a much higher chronic pain rate after the procedure, and also preoperative pain is a risk factor for postoperative chronic pain, and also postoperative complication do negatively influence the chronic pain rates after umbilical hernia repair. When you look to the recurrence rate in 1 year follow-up, then you see open suture has a negative influence in comparison to open mesh. Female gender has also a negative influence on the recurrence rate. I think this is due to a higher rate of rectal diastasis in female patients, which lead to a higher recurrence rate in the 1 year follow-up. This is my last slide. I hope I could show you how important registry data are. I'm always very happy to see the excellent papers coming out of the French registry, which now also has a high number of cases in the registry. And when we compare our outcome data of HerniaMed registry with the French registry, that we always see comparable results. And this is a very strong support that all our data are reliable. And now my paper is open for discussion. Thank you very much.